It's fine now, right? That waiting room, I removed the waiting room, ma'am. I removed the waiting room. That's why it got disconnected. Now it's all okay.
Okay. Thank you.
Yeah, and the recording, everything I'll share tomorrow. I just got an approval from Bhaskar as well.
I need numbers recording also.
Yeah.
Good evening, Dr. Bhaskar. Thank you, dear. Dr. Baswan Gowda, good evening.
Hello, Dr. Vanitha. How are you?
I'm fine. How are you, doctor?
Yeah, doing good. Thank you. A great initiative by you. Really highly appreciated.
Thank you, doctor.
Yeah. Great going and keep it going. Okay.
For sure, doctor.
Yeah.
How are you?
Okay.
How is it? Actually, I'm around in Bangalore. I met Dr. Ranjan a couple of days before. Please stay in for the CME, doctor.
Sure. I'm here. Okay. Thank you.
Good evening, Dr. Vanitha. Good evening.
Good evening, Dr. Bhaskar. How are you?
Fine, thank you.
Yeah, meeting
Nice
first time.
Yeah, nice talking to you.
Nice
So
talking
nice.
to you also, doctor. I was just texting you to send a reminder.
Yeah, I joined, but they had not started. So
Yeah,
I
same with me because it was told 6 p.m. for Indian time. So I joined earlier.
Yeah.
And I
But actually it is
disconnected
6:30 now.
waiting for them.
6:30.
It's 6:30. Exactly. But then maybe they gave a margin time for us to get it going.
Yeah.
Thank you, doctor, for accepting our
No,
invite.
I should thank you.
Looking forward for.
Yeah.
We will get started in another 10 minutes, I think.
Okay.
Already 6:18.
Ma'am, I have made you the co-host.
Okay.
Yes, doctor. Thank you.
I will just try to share this slide and see.
Yes,
Yeah, it is all accessible.
It's accessible for both, right?
Yeah.
Yeah, okay.
Because I have another meeting sometime, so if in any case you can mute until you can do.
Yeah.
No problem.
Should I give anyone else also with this access?
For now, only me and Dr. Bhaskar. Maybe after Dr. Mohammed Salman joins in, because I'll let him coordinate the Q&A session if he is around.
Is the slides visible, ma'am?
Yes, sir.
Visible, no?
Yes, sir.
Bhaskar sir, I have made you also the co-host.
Okay. No problem.
Because I have another call at some time, so if that happens,
please.
yeah.
You can proceed. I will manage in the meanwhile, Mr. Saji. Are you likely to rejoin?
No worries. Yeah, I'll be rejoining. Yeah, once that's done, I'll be rejoining.
No, that's fine. Okay, we'll manage in the meanwhile.
Yeah.
Thank you.
Thank you, ma'am. If you face any difficulty, just ring me up, ma'am.
I'll do that. Yeah.
I'll come back in 5 minutes. Okay.
Yeah.
Yeah, another 10 minutes are there.
Yes.
Don't log out.
Yeah.
No.
Yeah, because I've made you the co-host. That's why. No, madam has the whole access. She also can make you the host. No worries.
Hello, Dr. Vanitha.
Hi, doctor. How are you?
I'm all right.
Yes.
Are there two groups or all are in one?
I'm not too sure. I think it's one group.
Okay.
I mean, you mean the the audience from India and Bahrain are bifurcated?
No,
you
no,
mean?
not that way. Not that way. Panelists and you know the
No, it's
what you call.
it's a common group.
Okay. Okay.
No, the panel
Has
and
Bhaskar
delegates and
joined?
audience all same. Yeah. Yeah, he has
Has
joined.
Bhaskar
Doctor.
joined? Okay.
Yes, doctor, he is in.
Hello, hi.
Hi, Mohammed Salman. How are you?
Yeah, hi. I'm good. Hi. Good evening. How are you, sir?
Hi, Dr.
I'm
Salman.
fine.
Sorry, I'm in my way to reaching home. I just finished my duty, so
Okay.
I'm driving.
All right. Nice.
Yeah,
Nice to speak to you again.
We'll need you to coordinate our
Yeah,
next
it's my
session.
pleasure. My pleasure.
The December Christmas and New Year, this thing has started.
Yes.
Festivities.
Celebrations, yes, festivities.
Yeah.
By the way, Vanitha, I will send you that this thing. What is that?
You muted. Yeah. We can't hear you. You're muted.
So we'll start by 4, Vanitha.
Yes, we can start now. I think it's about time. Let me just check this out. Yeah, 4 more minutes.
Yeah.
Yeah.
You are in India now? Or?
Yes.
Oh, okay.
You happen to travel as well, right?
Yeah. I was in Iraq, in Basra. I participated in one conference there, non-communicable disease.
Okay.
Yeah, I present a lecture about the healthcare development, manpower development.
You can see
Just,
the audience sticking in. I think we can get started. Welcome back, Dr. Bhaskar Shenoy.
I'm here.
Yeah. That's our speaker. Good evening, all.
still
Welcome
there is
to
3 minutes. Still there is 3 minutes, Vanitha. Let's wait.
Yeah, I'm just talking to people who are logged in.
Yeah.
Good evening, Dr. Basavaraja.
Good evening, Dr. Vasavaraja.
Bhaskar
Good evening.
How are you, doctor?
Namaste.
Vanitha, madam, good evening.
Good evening, doctor.
Ranjan sir, good evening. He's not. Good evening, sir.
Good evening.
Good evening, Bhaskar. How are you?
Fine, sir. Thank you.
Mohammed sir, good evening. Good evening. Hi.
Good evening, Namaskar, Dr. Basaraj.
Good evening. Vanitha madam webinar test, we did not want to miss it.
Oh, thank you very much, doctor.
See, he didn't mention Bhaskar Shenoy, he mentioned Vanitha.
No.
Hey, Bhaskar.
You are the
No,
star of the event,
see,
doctor.
both the things are from both of them are from this one, no, stalwarts. Huh?
Bhaskar.
Sir.
ನಾಡ್ದು ಶನಿವಾರ ನೋಡ್ರಿ ಪುರ್ಸೊತ್ತಾದ್ರೆ ಬನ್ನಿ ಬುಕ್ ರಿಲೀಸ್ಗೆ. ನೀವು
Okay, sir. Okay, sir.
ಕನ್ನಡದ ಬಹಳ ಇವರಲ್ವಾ, ಅಭಿಮಾನಿಗಳಲ್ಲ?
Is that right?
ಇಲ್ಲ ಸರ್, ಭಾಸ್ಕರ್
President-
ಬರ್ತಾರೆ ಸರ್, ಅವರು ಫ್ರೀ ಮಾಡ್ಕೊಂತಾರೆ ಸರ್.
ಪ್ರೆಸಿಡೆಂಟ್ ಸಾಹೇಬ್ರು ಈಗ ಶುಕ್ರವಾರ ಶನಿವಾರ ಇವತ್ತೇ ನಂಗೆ ಅಲ್ಲ, ಇದು ಆನ್ಲೈನ್ ಸಿಗ್ತಾರೆ, ಬಟ್ ಫಿಸಿಕಲಿ ಸಿಕ್ಕುದು ಕಷ್ಟ ಈಗ, ವರ್ಷದ ಕೊನೆ ಅಲ್ವಾ?
ಕರೆಕ್ಟ್ ಆಗಿ ಹೇಳಿದ್ರಿ ಸರ್.
ಸೊ ಹಾಗಾಗಿ ನಾನು ಅವ್ರಿಗೆ ಹೆಚ್ಚು ಒತ್ತಾಯ ಮಾಡುವುದಿಲ್ಲ. ಅವ್ರು ಮತ್ತೆ ನನ್ನ ಇದಕ್ಕೆ ಎಂತದ್ದು ಜರ್ನಲ್ ಇದಕ್ಕೆಲ್ಲ ಬಂದಿದ್ದಾರೆ. ಇದು ನನ್ನ ಲಾಸ್ಟ್ ಫಂಕ್ಷನ್ ಈ ವರ್ಷದ್ದು.
ಓಕೆ ಸರ್,
ನೋಡಿ ಟ್ರೈ ಮಾಡಿ. ಅಲ್ಲಿ ಮಾರ್ತಾಸ್ ಹತ್ರವೇ ಮಿಥಿಕ್ ಸೊಸೈಟಿ.
ಓಕೆ ಸರ್, ಡೆಫಿನೆಟ್ಲಿ.
ರಿಸರ್ವ್ ಬ್ಯಾಂಕ್ ಎದುರುಗಡೆ. ನಾನು ನಿಮಗೆ ಕಳಿಸಿದೇನೋ ಇಲ್ವಾ ಗೊತ್ತಿಲ್ಲ, ಕಳಿಸ್ತೇನೆ.
ಸಿಕ್ಕಿದೆ ಸರ್, ಸಿಕ್ಕಿದೆ.
ಹೌದಾ ಬಸವರಾಜ್?
ಎಸ್ ಸರ್.
ಎಲ್ಲ ಹೇಗಾಗ್ತಾ ಉಂಟು? ವೈಂಡಿಂಗ್ ಡೌನ್?
ಎಸ್ ಸರ್, ಎಸ್ ಸರ್, ಎಸ್ ಸರ್.
ಇಲ್ಲ ರೀ, ನೀವು ವೈಂಡ್ ಡೌನ್ ಆಗುದಿಲ್ಲ, ನಂಗೆ ಗೊತ್ತು.
Well said.
ಹೌದು.
It was a promising presidency.
No, I need to concentrate on other work, sir. That is why I'm moving up, sir.
Yeah. Personal life, maybe.
Yes, sir. My daughter is 10+2.
ಸಿ ನಾನ್ ಯಾಕೆ ಹಾಗೆ ಹೇಳಿದ್ರೆ 100% ಅಲ್ಲ, ಪ್ರೆಸಿಡೆಂಟ್ ಅಂತ ಒಂದು 80 to 90% ಎಫರ್ಟ್ ಹಾಕಿದವರು, ಇದು ಸ್ಟೆಪ್ ಡೌನ್ ಆದ್ರೆ 50 to 60 ಆಗ್ತದೆ. ಇವರು 150% ಹಾಕಿದ್ದಾರೆ. ಸೊ ಸ್ಟೆಪ್ ಡೌನ್ ಆದ್ರೂ 120 ಆಗ್ತದೆ.
That is right, doctor. His mathematics, no dispute on it.
Mohammed sir, good evening.
Hi, good evening.
Good evening, sir. Good evening, sir.
Hi.
Yes, I think it's time. At least it's time in India.
Yeah, it's here all.
Yeah.
Yeah. Okay. Good evening and welcome all. Welcome back to the December session of IAP AMH CMEs. As most of the audience who are here know that we are doing monthly CME sessions along with Indian Academy of Pediatrics. Indian Academy of Pediatrics is conducting pediatric subspecialty CMEs every month online, 4th Sunday at 4 p.m. Tentatively, that's been decided. We had an inaugural session on October in pediatric endocrinology and pediatric obesity. November, we had a very interesting session, a bouquet of CMEs ranging from perinatology to pediatric intensive care, and it was very fruitful. And here we are for the December session, and our subspecialty for this session is pediatric infectious diseases. As we all know, protocolized care is the order of the day in medicine these days. Protocols and algorithms designed over evidence and graded evidence is the order of medicine these days. And so is the protocolized care in pneumonia. There is protocols for prevention, vaccination. There is protocol for diagnostics using biomarkers, using microbiological diagnostics like the cultures, imaging to use or not to use, when to use, what modalities of imaging to use, as well as the star of the debate, the antibiotics. The choice of antibiotics, using the right antibiotics, the oral, parenteral, the duration, short versus conventional course, all these have been protocolized in medicine in pneumonia. Despite all the protocolized care, there is this complicated pneumonias happening. So we are challenged with the question, are these complicated pneumonias different entities? Are they different phenotypes? And can we map these phenotypes? These kind of perplexing questions we will have Dr. Bhaskar Shenoy answering us in his interesting lecture pertaining to infectious diseases. I'll introduce Dr. Bhaskar Shenoy before we get started with the CME. Thank you all for joining. Let me introduce Dr. Bhaskar Shenoy before we get started. Dr. Bhaskar Shenoy, welcome.
Thank you.
I would like to post your CV. Dr. Bhaskar Shenoy is currently the head of Department of Pediatrics in Manipal Pediatrics and Pediatric Infectious Disease Division, Manipal Hospital, Bangalore. He's adjunct professor of pediatrics, Manipal University. He has multiple accolades in the form of authoring several peer-reviewed journals and peer-reviewed textbooks. And the topmost of them are, as noted in the CV here, Best Case Award by ESPN in 2020, Bill Melinda Gates Travel Award 2023. He is the Joint Secretary, Indian Society of Kawasaki Disease. He's Honorary Secretary, PEDA 2022-23, Chairperson-elect PEDA 2024. That's the brief abbreviated CV of Dr. Bhaskar Shenoy. Dr. Bhaskar Shenoy, the floor is yours. Please start your presentation.
I think before that, hello?
Yes, doctor, please go ahead.
Dr. Basavaraja to speak few words.
Yeah,
And
Dr.
Dr. Vasant
Basavaraj.
Kalathar.
Yeah, that would be interesting.
thank
And
you.
Dr. Vaisam, also please top it up. Please, Dr. Basavaraj.
Yeah.
You can.
Thank you very much, Dr. Vanitha, our IAP Bearing Branch and AMH American Mission Hospital, which has been very, very instrumental in organizing this in association with our Indian Academy of Pediatrics, with our international liaison committee convener, Dr. Ranjan Pejawar, sir. I'm sure the two faculties which is going to share their experience, one our infectious disease expert and stalwarts, Dr. Bhaskar Shenoy, and Dr. Vanitha Jagannath, who has been doing an excellent work, especially the focus talk. Just I was there in a physical CME at Bahrain, and the use of a focus in a pediatric intensive care that day was a mesmerizing talk, which was being delivered. I'm sure today's talk also it is going to be very, very useful. Both the stalwarts are here, and our president-elect, our incoming president, Dr. Vasant Kalatkar, is also here. So, and Dr. Professor Singaru Velu, Dr. Yogesh Parik, Atanu Bhadra, all were supporting the things. The best wishes for the program. The Bhaskar, just before you speak, I request Dr. Vasant to say a few words.
Yeah, good evening all from India. I welcome you all for this is a novel project because Dr. Vanitha, thanks for taking really initiative and really this is the need of our today that one should get united, collaborate, and that had been done by Dr. Basavaraja, Dr. Yogesh, Dr. Atanu, that they have made a collaboration and now I was thinking since when I was the ID chapter chairperson in 2018, that time myself and Bhaskar was thinking about this project, but it's in reality because of Basavaraja only. Thank you, Basavaraja, for collaborating this, and I hope with my effort and your effort, we will continue this project because most of the members I saw in Bahrain, they are originally from our place, like brothers, sisters. So it is always better to exchange knowledge in between us. So this collaboration, we will continue. Thank you, Bhaskar and Ranjan, for doing a great job. Really great. So IAP is always with you for very. I think we will go for next year. We will go for a big thing, big, right? Vanitha, I invited you for a pedicon. I think you are not coming. I came to. So
I probably not possible, doctor, but one of our doctors, Dr. Pramara, probably will be visiting you.
Yeah, we will miss you. This is this pedicon. Let's hope next pedicon in Calcutta.
Maybe if
Atanu
I
will
talk
invite
something,
you.
I will be compelled to come. I will come for
Yeah.
sure, doctor.
So it should be exchange program. I always
Yes,
think
doctor.
so. I
Yes,
wish
sir.
all the best for IAP Bahrain branch, and thank you, my IAP friends, India branch. Thank you.
Thank you, Dr. Basaraj, and thank you, Dr. Vasan. Can we proceed with Dr. Bhaskar?
Yes. Let me share this slide.
Yes, doctor.
Good evening, respected Dr. Basavaraja, Dr. Vasant Kalatkar, Dr. Ranjan, and all the luminaries of IAP. Dr. Ranjan for giving me an opportunity, and all the faculties and staff and management of American Mission Hospital, and Dr. Vanitha especially. Today, I am going to talk about the conundrum of complicated pneumonia. In fact, the complicated pneumonia has become maybe more, the incidence is more, or we are able to recognize it more, and we have been able to manage it in a better way. How much better we can do. These are the things I'm going to talk today. As we know, pneumonia claims the lives of the vulnerable children. And if you look at the cause of death, it remains the leading cause of infections among children, and about 16% of the total under 5 deaths are contributed by pneumonia. And the worst part is that most of the victims were less than 2 years old. Now, when we say what is the complicated pneumonia, the pneumonia causes death, the cause of high mortality is either a severe pneumonia or a complicated pneumonia. So what is a complicated pneumonia? Let us first define the complicated pneumonia. An infection involving the lung parenchyma, which is complicated by one or more of the following, like parapneumonic effusion, empyema, necrotizing pneumonia, lung abscess, pneumothorax, or bronchopleural fistula. When should I suspect a complicated pneumonia, especially in the pediatric age group? So when you diagnose pneumonia, you have started appropriate antibiotic, but failure to improve clinically after 40 to 72 hours of proper antibiotics. That indicates a complicated pneumonia. And your antennae should be high when the child doesn't respond to the conventional antibiotic appropriate dose given appropriately within 72 hours. The symptoms and signs and radiological features, they disappear in various time. The usual duration of findings in community acquired pneumonia when it is treated, the tachycardia and hypotension, maximum 2 days, fever, tachypnea, hypoxia, cough. Tachypnea and hypoxia can persist 3 days. By 3 days, it should come down. Cough may persist longer, and infiltrate on the X-ray may persist even after a few weeks. So complicated pneumonia has to be suspected within 48 to 72 hours. The clinical features, it can be fever and the respiratory rate more than 70 in children, infant, and in children it is more than 50. The distress as indicated by nasal flare, grunting, head bobbing, apnea, cyanosis, etc. Capillary refill time increases, the saturation comes down. The various complications that we see in pneumonia can be classified both in pulmonary or extrapulmonary. When it pulmonary, you have, as I told, parapneumonic effusion, empyema, lung abscess, embolism, ARDS, etc. But many of the extrapulmonary complications are also can occur. For example, pericardial effusion, dissemination. They can develop bone and joint infection. They can develop meningitis, SIADH, septic shock. It can be metastatic infection elsewhere or multi-organ failure. Now, what is the proportion of complications? So this is a particular study wherein a retrospective analysis about 144 children complicated pneumonia, and most of them were 1 to 4 years. 40% of them had parapneumonic effusion, and another 40 had empyema, and 20% had necrotizing pneumonia. And this is a study of around 2017. The microorganisms responsible for the complications, most of them were Streptococcus pneumoniae and group A Streptococcus, followed by Staphylococcus. There are one more study wherein the parapneumonic effusions, they found that it developed in 1 in every 100 children with community-acquired pneumonia. But if the child is hospitalized, the proportion may go as high as 40%. Now, why should I talk about complicated pneumonia? Because the problems with complicated pneumonia is that the etiology is uncertain. See, most of the times in pneumonia, it is very difficult to find out the etiology. Then the diagnosis becomes uncertain, the management is uncertain, and the course is unpredictable. All of a sudden, the child may worsen in spite of appropriate treatment. That is more important, which I'm going to touch in the future slides. So let us look at the etiology and pathology. There are a lot of studies done. One is the landmark studies, or one is the Gabriel study, wherein it was done in 8 developing countries to look at the common microorganism. Streptococcus pneumoniae becomes the #1, followed by some viruses like RSV, human metapneumovirus, parainfluenza, influenza. The Perch study also was done. It showed that the viruses accounted for 61%. Maybe the PCR was used as a modality of diagnosis. So the viral diagnosis became more, and RSV had the greatest etiology factor. Other viruses were also there. And then the other study was the EPIC study. This was done more in US, wherein 3 major hospitals, the burden of admission, burden of hospitalization in children younger than 5 years was also studied, but the viruses became the more common etiology. Now, the etiology, when you look at, as I told, the Streptococcus pneumoniae, Staphylococcus, but Mycoplasma also has been doing, contributing more. The other viruses are the Staphylococcus, etc. But the organisms which I'm showing now are more in immunocompromised than in an immunocompetent child. So this is just a brief of the etiology of pneumonia, and even the etiology may change, the microorganism, depending on the age. For a child who is 1 to 3 months old, it can be Streptococcus pneumoniae, but Streptococcus pneumoniae is the major organism across all the groups. The younger infants, they will have more of viruses, chlamydia, etc. The less common are group A Streptococcus, group B Streptococcus, but H influenza has come down after the vaccination programs. So similarly, the more than 5 years, Mycoplasma and respiratory viruses take over the lead. In an immunocompromised child, all the rarer organisms, maybe Burkholderia, Mycobacterium, pneumocystis, etc. So when you look at the pathogenesis, why it becomes more aggressive, we know that the capsule of polysaccharide for pneumococcus that assists in interacting with the epithelium, that avoids the entrapment by the nasal mucosa and then inhibits the opsonophagocytosis during the infection. When the pneumolysine is another antigen which breach the membrane of the barrier of the cells as a pore-forming toxin, they activate the complement, inhibit the neutrophil respiratory burst, release the antibacterial, vasodilatory, and nitric oxide from the macrophages, and in the later stages, they cause lysis of the tissues. That leads to widespread damage to the host tissue. When it comes to Staphylococcus, it's the alpha hemolysin. that is known to activate the NLRP3 inflammasome. Inflammasome is a multi-protein complex that plays a key role in innate immune system by activating the inflammatory response and cell death. It is activated by danger signals and even by the microbial patterns that determines the production of this inflammasome, and that induces the IL-1 beta production that leads to programmed necrotic cell death. And this alpha hemolysin is known to induce platelet neutrophil aggregation, and that leads to alveolar capillary destruction. And this particular thing is specially seen in necrotizing pneumonia. The necrotizing pneumonia can be a shared consequence of numerous virulence factors. I have noted down all the virulence factors, but the common one is the PVL and the alpha hemolysin, etc. I don't want to go into the details of that. The other important thing is the pentavalent leukocidin, which is a pore-forming toxin that consists of two components, SPV and FPV. So that forms pores in the cell membrane of phagocytic leukocytes, especially polymorphs, and that leads to leukocyte destruction, thereby leading to tissue necrosis. That is a strong inducer of release of histamine and pro-inflammatory mediation, and increased influx of polymorphs and inflammatory cell infiltration occurs, vasodilatation occurs, thereby that leads to tissue injury. That is responsible for the necrotizing pneumonia caused by both MRSA and MSSA. Of course, now there are a lot of talks of mycoplasma pneumoniae causing the complicated pneumonias. So what is the cause, or what is the toxin that causes? It is called as CARDS toxin. CARDS toxin is community-acquired respiratory distress syndrome toxin. Then membrane lipoproteins, hydrogen peroxide, superoxide. These are the factors that is produced by mycoplasma that leads to what you call as the virulences. Now, the CARDS toxin is the only exotoxin produced by mycoplasma pneumoniae, and that causes ADP ribosylation, and that induces inflammatory response, again by acting NLRP3 inflammasome. So that particular toxin causes the lysis of the membrane, and as I told, the hydrogen peroxide, superoxide are also generated by mycoplasma pneumonia that leads to cell injury. Now, most of these severe pneumonias or the complicated pneumonia, most of them have in the background a viral infection. The viral infection causes some more susceptibility to these complicated pneumonias. The viruses acts by decreasing the bacterial clearance. That is why the epithelial barrier is disrupted, the mucociliary function is impaired, and bacterial adherence is increased, and modulation of the immune function occurs, downregulating of the macrophage phagocytosis occurs, neutrophil intracellular killing is decreased, apoptosis, that is cell death, is induced. So this is the mechanism of viral bacterial infection. This is the mechanism how the previous viral infection makes the child more susceptible to pneumonia, and especially complicated bacterial pneumonias. And when you come to the lab test, the CBC, that is complete blood count, that may not throw much light into that, except in a severe pneumonia. If the counts are less, if the white cell counts are less, and the platelets are less, that indicates a severe pneumonia. Especially it can occur in the toxin producing organism, the PVL producing organism. Blood culture, the rate of blood culture, the yield of blood culture in pneumonias is very less. And some of the advanced centers, even in the West, they have done these studies, and they found that the culture positivity in these pneumonias ranges from 2 to 10%. Some studies, it was about 20%. Viral respiratory testing, Of course, it can give, but sometimes it so happens there are 2 or 3 organisms, one viral, one bacterial is identified, and that leads to confusion. But always it is better to treat as a bacterial infection because it is very difficult to differentiate between the two. The acute phase reactants do not help you in making a diagnosis, but more it helps you in following the response to treatment. And respiratory samples, especially the lower respiratory samples like sputum if possible, pleural fluid and ball whenever it is done. Now, the pleural fluid, when it is removed, the LDH, if it is quite high, more than 1000, that usually indicates it is in necrotizing pneumonia, and serum LDH is also will be high. And that indicates a possible ongoing necrosis or liquefaction. Similarly, the serum albumin will indicate in some children severity of the clinical condition, and it is found that those who have complicated pneumonia will have a lower serum albumin levels. Of course, it recovers once a child recovers, and then it is a good predictor of mortality. Very low albumin, we should be very cautious. A retrospective study which showed that the serum albumin less than 3 milligrams or the 30 gram per liter is an independent risk factor for massive necrosis. So there are few guidelines, but one of the guidelines which I follow is generally the IDSA guideline. But this is 2011. Later, it was made some changes. So with that background, let me discuss a few cases and how we proceed. The first case is a 3-year-old child, high fever, 7 days, chest pain, abdominal pain, then fast breathing and difficulty in feeding. He was sick with the tachypnea, with the saturation borderline, and he had respiratory distress. It was rapidly progressing pneumonia. And this was the X-ray. If you can see, whenever there is an X-ray, we need to look whether there is any pulmonary involvement, pleural involvement, or we may have to look at the extrapulmonary. Here, extrapulmonary, we don't know, but pulmonary, you have a pneumonia, pleural involvement is there. And the X-ray showed large effusion with the cavities, and the opinion was that it was empyema with necrosis. This is another child wherein they showed large pleural effusion, which complicated the community acquired pneumonia. So when such picture is there, we are stuck with whether it is a parapneumonic effusion or it is empyema. So once to confirm that, should we do ultrasound, should we do a CT, or should we go ahead with a TAP? So here, when ultrasonology is the primary imaging modality, and especially to evaluate the pleural space, it is very useful, and it predicts the development of complication. It recognizes the early features. If you look at the two ultrasound the pictures here, so one is this particular thing is a simple effusion, whereas this one is a loculated effusion. You can see the loculations here. So ultrasound will help you to find out these things, differentiate between these things. It is found to be more sensitive than the chest X-ray to detect the effusions, fibrinous septations, and effusion from consolidation. And even for guiding the pleural catheters, it will help. And one thing is the Doppler ultrasound will be more useful, especially when you suspect necrotic changes and necrotizing pneumonia. This is the ultrasound wherein the pleural effusion and the multiple cavities. And this is one, the first one is the simple pleural effusion with uniform echo density. This is a complicated, complex loculated effusion, has so much of debris. So ultrasound is able to differentiate. And sometimes when you compare the CT with the ultrasound, this is the CT wherein the pleural fluid appears inhomogeneous. Whereas here in ultrasound, it showed numerous fibrin strands are better visualized on chest ultrasound. Similarly, this particular 4-year-old child with pneumonia and empyema, the parapneumonic effusions are seen, and then here you can see the fibrin bands in the pleural fluid. So this is a beautiful article which compared the ultrasounds and CT in the evaluation of pneumonia complicated by parapneumonic effusion, and especially the all the cases were children. So the outcome of this particular study is that chest ultrasound data is similar to chest CT. So chest ultrasound gives same information as chest CT, and when it comes to the consolidation, necrosis or abscess, the chest CT did not provide any additional clinically useful information that was given by the chest ultrasound. And the advantages of ultrasound is that the cost is better, the transport need not be sedation, all those things. So I think Dr. Vanitha will be talking more about that. Now the guidelines for drainage of you find out you are diagnosed parapneumonic effusion, and what are the guidelines? This is taken from the IDSA, wherein if the effusion is small I mean less than 10 millimeter on lateral decubitus X-ray, or opacifies less than 1/4 of the hemithorax, here no active intervention is necessary. The sampling is not required. Whereas the moderate, wherein it is more than 10 millimeter rim of fluid, but opacifies less than half of the hemithorax, that is called as moderate. Here, you look at the clinical picture. If the child has respiratory distress, if the child shows signs of empyema, then yes, you have to intervene. Otherwise, not required, but a follow-up is needed. But in a large effusion, wherein it opacifies more than half of the hemithorax, where the tube drainage with or without fibrinolysis or what, some kind of intervention is must in these cases. So the pleural fluid, you look at the pH, cell count, LDH, sugars, protein, microscopy, culture, even PCR you can do. This particular child continued to run fever, high fever, even after 48 hours of chest drainage and antibiotic. Now, how should you proceed? So should I continue the antibiotics and see, should I change the antibiotic? Should I repeat the imaging, or should I refer? CT was done, which showed the effusion, empyema. And then now the options come for the treatment. Should I make the child undergo surgery, VATS versus decortication, continue appropriate antibiotic, or fibrinolysis, or thoracotomy tubes? So when it comes to the antibiotics are the mainstay in the treatment. But if you are able to get a organism, if you are able to demonstrate a organism, Streptococcus pneumoniae, either high dose amoxicillin or with clindamycin. But intermediate resistant organism, ceftriaxone or linezolid. Staph, you have to give cloxacillin or cefazolin, and MRSA you can give vancomycin also, and community acquired MRSA, vanco or clinda. The duration of the antibiotic, especially when there is empyema, the antibiotic course should be longer. It may be 2 to 4 weeks should be the course of antibiotic. And initially, till the patient is stable, and the fever comes down for at least 24 to 48 hours, then we can look at changing over the antibiotic to oral antibiotic from IV antibiotic. But the total duration should be 3 to 4 weeks. Always the question asked, VATS is better or the fibrinolytic is better? And this particular new recent article, which is a meta-analysis published in November 2023, wherein they looked at the one research question in children with parapneumonic effusion or empyema, do hospital length of stay and other key clinical outcomes differ according to the treatment modality. So here they tried to look at chest tube with fibrinolysis, thoracotomy, wards, and chest tube alone. And they found that the outcome of all the methods were same. The duration of hospitalization is little more with only thoracotomy, and cost was better. The results of this network meta-analysis showed that chest tube alone was associated with a longer length of stay compared to other treatment modalities and lower cost with the fibrinolytics. So now the question is, intrapleural fibrinolytic is found to many centers are practicing, and they shorten the hospital stay, and especially with the thick fluid with the loculation or empyema, it can be used. And there is no evidence that one is more superior, but the most studied is the urokinase, which should be given twice daily for 3 days, 6 days, 6 doses in total. So depends on the weight of the child. 40,000 unit in 40 ml of saline in weighing 10 kg or more. In a child weighing 10 kg or less, it is 10,000 units. When do you think of surgery? When the child fails to respond to the chest tube drainage, fibrinolytic, etc., persisting sepsis is there, persisting collection is there, organized empyema in a symptomatic child. So this child was treated and it became and recovered well. The second case, again, similar case with fast breathing, fever, and difficulty in feeding. Is sick looking with the respiratory distress, and this is the X-ray, and then ultrasound thorax was done, thoracotomy was done, parapneumonic effusion, and we could grow the virus, bacteria, that is Streptococcus pneumoniae, started on appropriate antibiotic, but the fever continued, child continued to be toxic, child continued to be in distress. So what do you do? So we have the option. So continue the antibiotic, change the antibiotic, look at the collection, or CT thorax. CT was done. To our surprise, there were multiple cavities. You can see those cavities. Hope you can appreciate those things. So these are the other CT pictures wherein the A and B are the early CT findings of necrotizing pneumonia. These are frank necrosis, frankly developed. You can see the air-filled cavities in those things. So what is necrotizing pneumonia or necrotic pneumonia? It is a fast progressing complicating pneumonia in otherwise healthy immunocompetent subject. So it need not become bad in a immunocompromised child. Most of the patients are immunocompetent. The destruction of the lung occurs, small cavities occur, and usually accompanied by parapneumonic effusion or empyema. The fever, cough, tachypnea, distress, all those things. And most of the cases have accompanying PP or empyema. And the clinical spectrum, I have already told, they can go into the complication like bronchopleural fistula, they can develop pulmonary hemorrhage, and rare cases, they can go into gangrene also. And most of these are diagnosed in CT than X-ray. X-ray is not the modality to diagnose pneumonia, necrotizing pneumonia. The organisms causing necrotizing pneumonia are, most of them are pneumococcus and staph, and various other organisms also can cause. But the most important we should remember is one is staphylococcus, other is pneumococcus. Staphylococcus, either MRSA or MSSA, which produce PVL. We already discussed about that. And when it comes to the pneumococcus, the type 3 and type 19A are the two serotypes that causes severe forms. So clinically suspecting necrotizing pneumonia is a child who is come with pneumonia, who is unusually sick. There is a rapid deterioration and poor response to appropriate antibiotic, and even after ICD, he has some air leaks. And chest ultrasound with the Doppler, CT with contrast are the ideal imaging modalities for these patients. And when it comes to the staph aureus strains that produce PVL, so if the child with the pneumonia has influenza-like symptoms, hemoptysis, erythematous rash, declining white cell counts, and circulatory and ventilatory issues, so that is the time you can always suspect probably it is a PVL producer. The biomarkers for PVL producing staph, as I told, high CRP, hypoalbuminemia, high count, or sometimes in a severe case, low count, and skin rashes, leukopenia, etc. So management, which should be antibiotics, thoracocentesis, and tube thoracostomy whenever there is a need. Rarely it needs surgery, especially if there is a associated empyema or parapneumonic effusion. The third case is a 18-month-old child with the high fever and had fever and rash 1 week back, and noisy breathing, distress. He had marked indrawing, and this is the X-ray. You can see a cavity which is marked here, and thinking that it could be a staph pneumonia, the cavity, the ceftriaxone and cloxa was started. Child deteriorated rapidly. The possibility is secondary pneumothorax, and you can see next day how it worsened with the pneumothorax. And it can occur, secondary pneumothorax can occur in underlying lung disease, and especially with the staph aureus, it is the most important inciting factor. The management, we need to drain, that is thoracostomy tube drainage, underwater drain with the suction, adequate ventilation. These are the most important modalities of management. The other complication which rarely occurs is the ARDS, where the pneumonia comes with the septic shock, hypoxemia, which is refractory to oxygen, then bilateral radiological anomalies. In these cases, they need a specialized care in ICU. Other rare thing which can occur is the embolism, the pulmonary embolism after mycoplasma pneumonia. The mechanism of embolism caused by mycoplasma pneumonia is that when mycoplasma pneumonia infection occurs, antibodies are generated, immune complexes are formed, and that induces leukocytes to migrate to pulmonary artery, and they release large number of inflammatory mediators and lysosomal enzymes. That leads to injury to vascular endothelial cells, and that's how the embolism occurs in mycoplasma pneumonia. SIADH also can occur in 1/3 of the complicated pneumonias, and dilutional hypernatremia, seizures, confusion are there. We have to have a appropriate fluid management. Some children may have hematological issues, which can be DIC, septic shock, septicemia, hemophagocytosis, HUS. HUS commonly occurs with the pneumococcus with the serotype 3 is most commonly causes that HUC. So to conclude, empyema, necrotizing pneumonia, lung abscess are serious complications of pneumonia in children. Early detection of complicated community-acquired pneumonia is crucial. It should be suspected in patients with pneumonia who do not respond to appropriate antibiotic. Mind you, appropriate antibiotics after 48 to 72 hours. Most of these require management in a tertiary care hospital. Imaging is an important tool in the evaluation. Initially, X-ray has to be done, but ultrasound and is a most important modality. Chest CT should be done in some selected patient. Microbiological diagnosis, of course, remains a challenge because getting a appropriate sample is very difficult in pneumonias unless you do a ball, unless you do a pleural tap. And molecular diagnosis have definitely contributed to more of the diagnostic, the sensitive than the regular cultures. And antibiotics, when you give, you should continue 3 weeks minimum, 4 weeks on an average. And appropriate antibiotic can be switched down to oral antibiotics when the fever has abated for 24 to 48. With early diagnosis and appropriate management, definitely the outcome of these patients will become very good. And thank you very much for your patient listening.
Thank you, Dr. Bhaskar, for this informative and very nice presentation. I'm sure our audience, they prepared their questions, but please, we will keep this question at the end of the presentation of the second speaker. So we'll take all the questions together. Our second speaker is our doctor who's behind all these event, Dr. Vanitha. She is the consultant pediatrician in American Mission Hospital. She's the pioneer in BOCUS, the point of care ultrasound. She have more than 30 years experience in different level of pediatric and neonatology. She conducted so many workshops, and she presented in a national conference regarding the point of care ultrasound. And I think Dr. Bhaskar is mentioned about the second level of the diagnosis is to use the ultrasound or the CT scan or chest X-ray. I think Dr. Vanitha will explore more about using of the point of care ultrasound in diagnosis of lung disease. Dr. Vanitha?
Thank you, Doctor.
Yeah.
Yeah. Thank you, Dr. Mohammed. Thank you, Dr. Bhaskar. That was very comprehensive outlook about really perplexing, complicated pneumonias. And you did have the job of unraveling the mysteries. Let me demystify the same by POCUS or point of care ultrasound. I will try and justify my title, and together we can unravel the conundrum that you have titled it. So thank you, Dr. Mohammed, as well for the introduction. I'll get started with my presentation. I will, in the initial part, I will give the basic overview of point of care ultrasound in lung ultrasound, as well as delineate the complications that were listed by Dr. Bhaskar, because from Dr. Bhaskar's talk, the audience would have gathered the complications of necrotizing pneumonia, the pleural effusion, the simple pleural effusion, the parapneumonic effusion, and complicated effusions, lung abscess, may all be the complications. And it is important may all have similar presentations clinically. And it is very important to distinguish one from the other because of the therapeutic decisions that differ in different complications. So that's where lung ultrasound will help. And point of care lung ultrasound is nothing but lung ultrasound, which will be done by us practitioners. So point of care ultrasound, again, to redefine it at this juncture, it's a lung ultrasound done by the practitioners at the bedside, at the point of care, and the image interpretation and evaluation and decision-making will all be at the point of care. So let me start with the objectives of my presentation today. I will make a brief introduction of lung ultrasound, and for all those who are uninitiated about lung ultrasound can also gather some basic outline. It's basically the artifacts, because lung ultrasound is not as similar to other modalities where you actually image the organ. You have pattern of artifacts which make the diseases what we will interpret. And this pattern has typical signatures for different clinical conditions, and we will summarize that, and we will see how we'll utilize that in the present context. So the present context is to delineate pneumonia and its complications by using ultrasound. And we will review, Dr. Bhaskar already summarized a couple of predictors, couple of distinguishing features between complicated and uncomplicated pneumonia, so that if you're earlier on having some information, you will be prepared, because early diagnosis and aggressive treatment is what is the key in management of complicated pneumonias. So we will integrate it all together to utilize it in management. So let's see chest X-ray versus lung ultrasound. This is a typical pneumonia in chest X-ray. The audience is all familiar with these features, how the radio opacities of lung field in chest X-ray would be visible in a chest X-ray. So this is lung ultrasound. It's very difficult to wrap your head around this because it's really not giving any imaging particulars to the notion of what we know as consolidation. This is the closest comparison I could get. This is mine. So chest X-ray is like the bird's eye view. It gives a whole imagery. You can see the worm that the bird is eyeing. The worm would have its own view. So the worm's eye view is what I would term as the lung ultrasound. So it's giving you more insights and details into the pathologic lung and gives you more perspective as to distinguish certain key findings, which will help you in decision making. So the bird's eye view, it might sometimes there is parapneumonic effusion, which can be missed, not so sensitive. It both look similar in chest X-ray. Whereas if you do the lung ultrasound, the insights that you get would be more insightful. So introduction to lung ultrasound. Basically, you're not imaging. It's not like ultrasound, which images other physical structures. You will not get a whole picture of what you're imaging. One gentleman called Dr. Daniel Lakenfield interpreted certain artifacts. These are all artifacts which you want to avoid in other imaging. These artifacts he compiled together to get some patterns and signatures, which helps to assess certain things in lung ultrasound. So in lung ultrasound, 5 cardinal signatures or patterns is what you need to know. It's all that you know. Any medical student trained for 1 to 2 hours can gather it all. After that, it's up to us to make proper evaluation and interpretation to use it in decision making. So it's not about the physical structure that you're imaging, but it's a set of artifacts. It's basically artifactual, not imagery, that you are gathering and putting it together. So the window with which you assess will be set of artifacts based on air causing certain features in ultrasound, fluid causing certain other features. Putting it together would be the signatures. So how actually do we do the imaging or the scanning? We use some people who are familiar with ultrasound would know there are 3 probes: the curvilinear probe, the linear probe, and the phase direct probe. The curvilinear probe gives you more deeper penetration and a wider view, but cannot give you well-resolved information, whereas the linear probe gives you closer, shallower information, but very detailed information. Phased array is basically for cardiac imaging, but it gives you intercostal perspective. So you could use either of the probe depending on the need. If you're using the areas that you scan are mapped, each hemithorax has got 6 zones. This is the conventional mapping, but there are different standards. More the regions you map, more detailed viewing you'll get and more accuracy, but suffice to use at least 6 views. You can see the anterior, the blue area, the yellow area is the lateral, and the green area is the posterior. Scanning this area gives representative information of that area and good enough to scan the information that you need to gather in lung ultrasound. So you need to know the divisions and the way you scan it. You can, if you are having acute dyspnea and you need emergency evaluation, you probably will not be able to zone-wise image. You can do a rapid scanning of the areas by either bicycling or lawn mowering maneuvers, and you will gather information in real time. You may not be able to save the images, but you will gather information to make your therapeutic decisions. So basically, at least 6 zones, standard views. The anterior zones are useful to evaluate pleura. Most of the inflammatory causes of the lung conditions that we encounter in children or otherwise is pleuropulmonic. So it is very useful to evaluate that, like pneumothorax or any subpleural consolidations on such. Whereas the lateral and basal information is gathered by using the curvilinear probe and in the basal regions, which is the yellow and the green area. That's the summary of the areas of scanning, with an understanding that more the areas, more accuracy of your scanning. How you do it is using the probe, just exactly how I'm showing in the picture. At any footprint, you will have 2 ribs and 1 intercostal view, and this is the intercostal window that you're trying to scan. The probe marker is facing the head of the patient, and the information you're gathering is shown in the image on your right side. The 2 ribs, anything which is white would be either air, bone, stone, or serosa. These are the 4 structures which appear white or hyperechoic. So the bones will guide you to locate pleura. This is our whole idea of lung ultrasound. So to localize the first horizontal line in your window is our purpose. That's the pleural line. So locate 2 ribs, which will be hyperechoic, and will cast a shadow which is black, anechoic. And in the intercostal space, the first line that you see is a pleural line. This is a classic intercostal view of the lung, and this is called the bat wing view. So what are the common 4 cardinal features? Just get familiar with this so that you can master the lung ultrasound with more acumen in this. A lines. The first horizontal line, as I said, is the pleural line, and equidistant parallel horizontal lines are the A lines. They are the artifact of reflection whenever there is air, no matter where. If it's in the lung, if it's in between the pleura, air presence causes A lines. These parallel horizontal lines are called A lines, and they are equidistant, and they are till the bottom of the footprint. There is no need to count these A lines. B lines, they indicate normal aeration, no matter where. The B lines are vertical artifacts caused whenever there is fluid, especially between the pleura or in the interstitium. And the more the number of B lines indicate more the number of fluid, loss of aeration, and they start erasing the A lines. And there's normal lung. If you scan yourself, you can see parallel A lines. And as there is any pathology where there is fluid accumulation, it could be consolidation or it could be pulmonary edema. Any of the 2 will start showing you vertical artifacts, which are called B lines. These are 2 cardinal signatures of lung ultrasound. So it's useful to count these B lines because more than 3 in a field would be considered pathologic, and more coalescent lines means more intense fluid accumulation. Another useful sign that you should know in normal lung is something called as lung sliding. You can notice the first line, which you call pleural line, it shows I was talking about the lung sliding. What you notice is this line, there is slight shimmering or like ants marching. That's what I wanted to show in the next video. The shimmering of the first line, if you notice, is when there is to and fro movement during inspiration and expiration. That's called lung sliding. You'll have to distinguish between the chest wall movements. Although there is no sliding, you might notice it. So that's why you'll have to always keep this imagery in your mind, the ants marching. You can see the ants marching because of pleural and palatal interface. So this is what is called lung sliding. So these are, so far we are dealing with what's normal signature so that we will know how to interpret it in pathology. This is another normal feature because of highly reflective pleural surface of the diaphragm. You whatever the beams shown on the direction will be seen as reflected on either side. So you will see the image of liver on the supradiaphragmatic surface if there is no pathology in the base of the lung. So if you see a mirror image of the liver, one thing is you need to distinguish it as an infradiaphragmatic structure. If you do movements, you will see it disappearing or reappearing. That means it's an artifact. And this artifact is useful for you to know there is no pathology in the lung base. This is another artifact called as, you notice there is the curtain of lung moving to and fro with deep inspiration in the lung base. This is called curtain sign, and this is useful also to distinguish no pathology in the lung base. So A line, sliding, mirror image, and curtain sign all are to rule out any pathology in the lung. So to summarize, A lines are parallel lines, horizontal, pleural lines sliding, B lines are vertical, emanating from the pleura, reaching to the bottom of the footprint, and that indicates presence of fluids. Now, let us examine the pleura. This is the most important key information we need to gather. Pleura, when you see in the intercostal view, you can see if it is irregular, that's what indicates inflammation of the pleura. And this is the key information that you need to gather. Whether the pleura is contour is normal or irregular, and wherever it's irregular, are the B lines shooting out from it. So this is irregular pleura, indicative of beginning of inflammation of the pleura. So as the inflammation deepens, you will see the increase in the depth of the changes that's happening in the irregularity of the pleura and accumulation of pleural fluid in the irregularities. This is called a subpleural consolidation. It's a sonological term, do not have any correlation with the pathology, but it's a useful sonological finding. Subpleural consolidation. You can see the irregularity of the pleura that we talked about, and you can see the anechoic spaces, and the depth of this anechoic space will be very important. Please know that, because we heard Dr. Bhaskar Shenoy suggest that there can be some predictors beforehand. It's a protocol for us not to image at the first go. Fever, cough, and normal presentation could also give key information whether it can be a future complicated pneumonia if you do sonographic assessment. So this subpleural consolidation ranging beyond 1 centimeters will be indicative of possibility of bacterial origin, and the depth beyond 5 centimeters already cautions you that it could be a future complicated pneumonia. So this brings us to the star of the imaging, that is consolidation. What do you find in consolidation in ultrasound imaging? This is near 80% sensitivity, and certain features are almost 98% specificity. So please note the features. You will see the irregularity of pleura, and the pleural margin, which is irregular, is pushed towards the area where the normal lung is adjacent to it, and this adjacent margin is called Fred sign. And in the field where you are noticing the irregularity, you can see hyperechoic spots. These are air-filled bronchioles. Akin to, in the chest X-ray, you see air bronchogram. You also see similar air bronchograms. And if it moves in and out of respiration, it's called dynamic air bronchogram. So the features of consolidation, that's the presence of fluid. Fluid appears black. You can see in the field. You can see the margin of adjacent to the normal lung, which is called Shred sign, and the bronchogram highlighted with air, called air bronchogram, which will be hyperechoic and it will be dynamic. When it becomes static, it's a possibility because of mucus plugging, and appearance of fluids in the bronchogram will appear like fluid bronchogram and anechoic, which means it's later stages of consolidation. As things worsen and more consolidation is happening, it will almost appear like a tissue. A tissue, we mean liver. Liver can be imaged in ultrasound. So you don't need artifacts for imaging liver. So it will start appearing like liver. So this is a feature called as hepatization. So please note all the signs. You can see hepatization, you can see fluids, anechoic spaces, you can see hyperechoic spaces, which are air bronchogram, and these can be dynamic, which is almost 98% specific for pneumonia. So I will show you with anatomical imaging from here. You can see it almost resembling liver. These markers are the vascular spaces which can be highlighted and air bronchograms which are hyperechoic. So I'll just run the video. There might be interrupting audio, but my apologies. So this is how it is. You can see hyperechoic spaces which are, you can see similar hyperechoic spaces infradiaphragmatic. That's actually air bubbles in the stomach. So you can see the diaphragm. This is the diaphragm. These are the hyperechoic spaces. Then you can see the shred sign. That is the border of the pathologic lung with the normal lung. That's the shred sign. So this is the whole picture of lung ultrasound in pneumonia. So these are all marked for you to interpret and get your assessment of consolidation a little more precise. So that brings to, these are all the normal signs, consolidation, simple consolidation, and now we are proceeding to the complications. We heard from Dr. Bhaskar's talk, the complications are effusions, which can be parapneumonic or complex effusion, can be necrotizing pneumonia, complications of pneumonia as such, the physical complications, and lung abscesses and cavity formation. Let's see how lung ultrasound as such or along with chest x-ray makes it a superior modality and how we can use it for monitoring and further assessment while you're treating. So parapneumonic effusion is presence of anechoic space adjacent to the consolidated lung, which we saw, and the amount of effusion compared to the size of the consolidation will let you decide about whether it is a predominant effusion or parapneumonic effusion. If the proportion of consolidation exceeds the amount of effusion, it is more or less simply by convention called parapneumonic effusion. So that's basically the best modality, no doubt about it, because fluid is quite well imaged in ultrasound, and you can see the anechoic space adjacent to the consolidated lung. So as I said, the size difference is what makes you assess if it's parapneumonic or if it is complex effusion. So ultrasound, it does catch the clue to pick up any non-resolving pneumonia, and parapneumonic effusion from the onset, if you can pick it up, you will know that you will be handling a little different course of management. So assessing in the outset would be a suggested option, which I will talk about. So effusion, otherwise, if it's not just parapneumonic effusion, you can see if it is in excess, you will see the transthoracic compression causing compressive atelectasis of the consolidated lung, and it will appear like floating in the fluid, which is called jellyfish sign. And because of the presence of fluid, you can notice the fluid allows imaging of the structures beneath it. So you can see the spine beneath it. This is classic spine sign, which is positive. It's positive in consolidation also, but this is one of the dramatic positivity. You can see presence of spine and highlighting of the diaphragm, presence of fluid, and atelectatic lung floating in the effusion. This would be effusion as the predominant picture than the consolidation. The complex effusion, we saw formation of locules, fibrin strands in the effusion. There's no other means that you can get insight into it unless you image with higher imaging like CT scan than the complicated effusion that can be picked with ultrasound. Chest X-ray per se will not give you a real picture of these locules, and this we saw has a different therapeutic decision making. So it will be very useful to use this imaging modality and pick it up in the as it's evolving. So this is complex effusion where you're seeing fibrin stands and locules. You can map the locules, you can get the complete picture of how complex it is, and it of course guides you for insertion of intervention also as thoracoscope. So let me summarize with effusion, the ultrasound, because this is one of the most important complex pneumonia that you'll be assessing using ultrasound. It is the space of separation of the pleura. So the separation of parietal pleura and visceral pleura is measured, and this gives you a rough volume, and different volumes have different therapeutic decision making. We saw it already. And this is called the quad sign because of the quadrilateral margin by different superior and inferior ribs, parietal and visceral pleura, and the lung adjacent to it. We saw these are the signs, the liver, the spine sign. Sorry. Okay, this is visibility of the spine, which is called the spine sign, and this is jellyfish sign where you're seeing the atlantic lung in the anechoic space. You will see dispersed, you will see scattered anechoic substances, which could be fibrin or some things called as plankton sign, which will be suggestive of complicated effusion, complex effusion. So if you use something called as M mode, you can see the atelectatic lung floating in and floating out, which is called sinusoidal sign, which is a useful sign to tell it is not a complex effusion. When it forms strands, there will not be any more sliding of the lung, and it will be no movement of these atelectatic lung. So this sinusoidal sign will be lost. So all these will give you an insight into whether you need to intervene, whether you need to be aggressive, whether it's complex, etc., as regards effusion. So there is another complicated pneumonia which needs to be assessed because this makes a different decision making. This is lung abscess. The lung abscess and empyema, lung abscess, it's on the periphery, and I think empyema may appear similar, and we need to have better interpretation to make different decision making. Lung abscess best left alone unless it is causing a lot of management recalcitrant suggestions. You need to leave it alone. Whereas empyema needs draining. So you'll need to make distinction. So an abscess appears like irregular margin lined cavity with anechoic space inside because of the fluid or pus, according to the echogenicity will be different and will have a border. Whereas a pleural effusion will, as we saw, will have definite smooth border, and the angulation will also be different. We will see that in the subsequent slides. So you need to know lung abscess in the X-ray will appear like this very clearly in the ultrasound. So value of lung ultrasound, of course, we saw this reference being quoted. It's very useful in predicting the complicated pneumonia with necrotizing changes also. So how ultrasound as such may not shine much light, but using additional Doppler we saw it's got equivalent sensitivity to CT scan. So if you find the widest area of consolidation and apply your Doppler, the hypoechoic area, when applied Doppler and showing good perfusion, would be stage 1. Loss of some amount of perfusion will already spell difficult necrosis stepping in, and extremely poor perfusion already tells that both the
Sir Vanitha, your sound is not clear.
Internet is unstable.
assessing
You can,
different
can
aspects of
you repeat?
complicated
Internet is
as the severity of decreased perfusion assessed by ALMA.
hello.
Vanitha, I think it's better to close your camera. Oh my God.
Which
Yeah.
I'm sorry, I think there is some difficulty in my connection. I've rejoined. I think I'm audible now.
Yeah.
Yeah, it
Yeah.
sounds, yeah.
Do I have to share again?
Yes. Yes.
Yes.
Okay.
I think.
That's fine.
Can you go
I'm
to
sorry for the
previous slide,
interruption.
madam? Can you go to previous slide because that was not
Yeah.
heard.
Okay, sorry, I'll do that. Okay, this is the most important slide comparing how ultrasound is useful in diagnosing necrotizing pneumonia. We saw that reference being quoted by Dr. Bhaskar. It is ultrasound as such may not have features to diagnose necrotizing pneumonia, but using it along with Doppler will give you as much sensitivity as the CT scan imaging, and particularly useful because you can use it for monitoring while the treatment as well as before starting the treatment to diagnose as well. So how it would be useful is find this is how the suggestion of using the modality goes. You find the widest area of consolidation and apply the Doppler. The consolidation, we saw the signs how it would be. If there is perfusion, it would be considered P0. Perfusion with reduction in the central areas would be considered P1. This you can appreciate the vascularity because of perfusion in the Doppler, whereas no perfusion in Doppler would indicate almost the final stages of necrosis and would spell you to get more aggressive in your management. The equivalent of poor perfusion in the CT scan would be the contrast enhancement lines are not seen. Contrast enhancement would suggest perfusion in the area, and loss of perfusion in the subsequent phases can be appreciated by using the ultrasound with Doppler. So you can see the severity of decreased perfusion is as good as grade of necrosis assessed by the CT scan. The point I'm trying to make is ultrasound along with Doppler can be useful in serial monitoring and assessing necrosis and its response to management as you are trying to use it in evaluation. This is one of the references suggesting us how to utilize it. So peripheral hypoechoic spaces, some necrotizing pneumonias suggest formation of pneumatoceles can also be picked up by ultrasound. You can see the hypoechoic space seen in the periphery of the lung, and these are called pneumatoceles, which can also be picked up. The pneumatoceles, there is not much that is done. You will have to manage it like how we are managing the primary necrotizing pneumonia. The only thing is you will have to keep your caution high for the pneumothorax complication. And pneumothorax, comparison of ultrasound and CT in assessing parapneumonic effusion, by now we would have gathered that it's almost superior or equivalent sensitivity by using ultrasound. Pneumothorax. This is the point I was coming to. Pneumatoceles and certain complicated pneumonias can further get complicated by this complication called as pneumothorax, wherein if it becomes a large pneumothorax, it causes tension pneumothorax, causing hemodynamic instability as well. Pneumothorax, this is by far the best way of assessing using ultrasound. Most ultrasound learners learn this as one of the first ways of learning emergency complications. So how do you find pneumothorax in ultrasound? We initially saw A lines are the harbinger of aeration in the space or in the sonographic window that you're assessing. So presence of A lines suggests aeration. Pneumothorax, this is air. But how do you distinguish from normal lung and pneumothorax is by this star finding called as lung sliding, which we saw. Absence of any lung sliding is to and fro movement of visceral and parietal pleura. This is lost if they are separated. If there is air in this pleural space, they get separated and you will not see the lung sliding. More important, as you start scanning and reaching the area where there is no pneumothorax, you will start seeing the sliding. This area of no lung sliding and lung sliding meeting is called as lung point. This is what is mapped here. You can see on the left side, there is lung sliding, on the right, there is no lung sliding and good aeration. There are a lot of A lines, but the line is not sliding on the left side. So this meeting point is called lung point and is very sonographical signature of pneumothorax. So we can confirm it by using the M mode again. M mode on normal lung will appear like this. This is called as seashore sign. Whereas on the pneumothorax, because there's no movement, chest wall appears like lines. Whereas pneumothorax also causing no movement will cause similar lines. This is called as barcode sign. So there is no sliding, but presence of A lines is indicative of pneumothorax. And if you can see the area of meeting sliding, it's called lung point, very indicative of pneumothorax and is almost 100% pathognomic specific for pneumothorax. So can chest X-ray, can computer tomography CT scan replace chest X-ray in pneumonia? This was already seen. Complicated pneumonias, it's very useful. Complex effusions, much more useful. This we already saw. This is one of the references I'm quoting. Chest ultrasound in the evaluation of complicated pneumonia. This is not in the initial phases, later in the ICU. It is a viable alternative for basic fact that it has got its advantages of being on the bedside and useful for monitoring. So it provides accurate evaluation of pleura and parenchymal abnormalities, and it can be used at bedside and avoids transportation of the patient, which was already mentioned, and free of radiation exposure. The lung ultrasound features with complicated and non-complicated community pneumonia. This is before considering the management. We are not using any X-ray at the outset, but we can start using lung ultrasound for management of these conditions. So are there predictors in the ultrasound features? It can already see with the same clinical pictures, you can see consolidation, or you can see viral pneumonia causing the same clinical picture, which can be assessed, which can be distinguished. It really gives you an objective insight. Now, can we gather any more objective insight, whether it is gonna be complicated or non-complicated in the course? That is, can they be used as predictors, is what this study suggested. So this did a prospective evaluation of complicated and uncomplicated pneumonias, and then the assessment signs, which are distinctly different from complicated and uncomplicated pneumonia, were the presence of subpleural consolidation. It's more deeper in the complicated pneumonias, and the nature of the air bronchogram, it's more punctate and arboriform like spider, whereas it's more dense in deeper in the complicated pneumonia. So this useful study gave us an understanding, along with using certain lab markers and other features, we can predict that the course of the pneumonia could be complicated. So at 0 hour and at 48 hours after treatment, they were mapped, the distinguishing features. So the air bronchogram, the nature of the air bronchogram, subpleural consolidation and the nature of the subpleural consolidation, as well as amount of pleural effusion, were all different, giving us a picture of the future course of complexity of pneumonia. So here is the suggestion of what I'll show you, the sonographic pictures of each one of these complicated pictures. This is called as hydropoint. You can see here there is air and there's no sliding, whereas there is anechoic space and there is sliding. This is called as hydropoint or effusion with sliding. If there is pneumonic, if there is empyema, you might find sliding, or if there is pneumothorax or hydropneumothorax, this would be your picture. You can differentiate pneumothorax and peripheral lung abscess. That's the sonographic features that I'm going to show you. So how would you distinguish? So in the major signs are the appearance. The empyema will be more lenticular, whereas the abscess, why this is important is already seen. Empyema needs draining, lung abscess best left alone until it really challenges you for drainage. So it's useful for you to distinguish the two. This is a bifurcating therapeutic decision making. So lung abscess appears round, whereas the empyema appears lenticular. The lung abscess may be completely anechoic and there is no smooth border of pleura. It's irregular wall and thick wall, which is not so with empyema. And you might see adjacent lung. If you do Doppler, you will see vascularity of the adjacent lung when it is lung abscess. Then you can see this is a sign called as suspended microbubble sign because of presence of the air in the empyema. You can see it sliding up and down with inspiration and expiration, and causes an image called as suspended microbubble sign, which is what you can see on the left image, and also see this hydropoint, which are making an angulation which is acute when it is abscess, whereas it's obtuse when it is empyema. These are distinguishing features which will help you to understand whether it's abscess or pneumothorax, because each one have different decision making. That brings me to a couple of slides as to predictors, which are not just sonologic. Here, this was one of the consideration discussed by Dr. Bhaskar already. Despite vaccination, most of the common etiology is PCV and staph and strep pneumonia, streptococcus as well, where you can see the incidence of pneumonia, although it's decreasing caused by streptococcus pneumonia. You can see the necrotizing pneumonia incidence have been showing no tendency as regards post-vaccination as well. This is the difficulty of pneumonia, rightly termed as a conundrum. So if we can pick up certain patient characteristics or certain predictors which can keep us cautioned to be prepared to foresee these complicated pneumonias, these some of the references which would help us. I will just portray some of them. So the changes in the different countries, I will just summarize. Germany, the incidences you can see of different organisms in etiology and different presentations. You can see them not showing any definite pattern, though there have been protocolized interventions of vaccination and antibiotic treatment. So there is not much you can make out of these incidence pattern. Can we predict based on certain features Dr. Bhaskar already summarized are the counts of the thrombocytes and albumin levels are all some of the features. This study exemplifies that. I'm not too sure if I'm audible again. Okay. The risk factors of local form complications is another study which exemplifies similar. An interesting thing that was found in this study was incidence of duration of fever as well as duration of use of ibuprofen seem to be one of the common predictor for the complications of pneumonia. Whether it is cause and effect relationship, we do not know. It cannot be explained. But one of the consistently repetitive finding that is found in repeated studies. So predictor risk factors for complicated pneumonia in another Malaysian cohort also suggest similar findings, but additional findings of parental smoking has been added as one of the risk factors. The other risk factors suggested in similar studies, as I saw, repeated consistency in certain features, biomarkers, that is acute phase reactants, albumin levels, and here the sodium level, which is also suggested as lower than 130, be one of the factors. That is an adult study, but having similar biomarker pattern in the pediatric pneumonia also. Ultrasound and ARDS, can there be any predictors of pneumonia? We saw there's not a very common complication that we encounter as PARDS, but then one of the later changes in definitions of ARDS started including ultrasound. You can notice the chest imaging, it suggested the initial Berlin criteria did not have any suggestions of lung ultrasound, but later definitions in the new global definition of ARDS started including lung ultrasound as one of the modalities, recognizing the importance of lung ultrasound in the field of diagnostics of lung pathologies. This is not PARDS, but then the utility of chest imaging lung ultrasound is by assessing certain features, presence of B lines and irregular pleura. You will distinguish pulmonary edema, which is what we need to do by basic difference distinction between ARDS and edema is needed, where there will be smooth pleura with good to and fro movements or sliding and B lines. Whereas in ARDS, you will have B lines with irregular pleura and classically areas of sparing in between areas of consolidation or pleura. So this is how you will find in ARDS, and the intensity and severity can be mapped and recruitment can be utilized by using ultrasound in repeated doing ultrasound. So can early identification of patients like which pneumonias can go to possible ARDS, can that be suggested by certain features? It is said amongst the many features, PEEP of more than 6.5, fibrinogen levels of more than 5.15, and the pH of less than 7.35 were suggested to be a constellation of these factors was suggested to be possibility of extrapolating to ARDS and subsequent mortality. So that brings me to the conclusion, summarizing some of the facts Dr. Bhaskar also presented. Pneumonia as such, community-acquired pneumonia has definite protocol of treatment, and if it doesn't contain in this frame of CAP treatment guidelines is when you encounter complicated pneumonia, and the complications range from parapneumonic effusion to necrotizing pneumonia to abscess and cavitation. Can they all be distinguished? Effusions and complex simple effusions and lung abscesses do not require any surgical interventions. Lung abscess, only when it's complicated and unresponsive, probably would need surgical intervention. And necrotizing pneumonia, you will have to keep the surgeon away, and you need to distinguish it as necrotizing pneumonia and not the cavitations of not the parapneumonic effusion or empyema. So you will have to make a distinction by using whatever modalities that you can do. So lung ultrasound with Doppler would be useful. And in empyema and effusions, hands down, ultrasound is the best modality. It guides you for therapeutic interventions also. And that's how ultrasound would be a useful modality. And as a point of care tool, this is one of the strongest bedside tools, and it's fast, it's accurate. Of course, no radiation. The trends can be appreciated, which is very useful as to tag the aggressiveness of your management. And early predictors, early sonographic features can help you be prepared for future complications. And the hallmarks, as I summarized, classic pneumonia has dynamic air program, hepatization stretch sign. With or without parapneumonic effusion, effusion will be anechoic space with atelectatic lung, or if it's complicated, fibrin stance can be seen. Necrotizing pneumonia will show impaired perfusion, formation of pneumatocysts can be seen. Abscesses and pneumothorax can be appreciated in ultrasound. ARDS, although not a very common complication, you can see B lines, irregular pleura, and areas of sparing. So lung ultrasound can be integrated with certain lab markers and clinical markers and chest X-ray information also to manage the pediatric complicated pneumonia as well. Thank you.
Thank you, Dr. Vanitha. And as usual, very informative presentation for the point of care ultrasound. And I think this is we will not say the future, it is the present of the using of this tool in the diagnosis and the follow-up and management of cases, especially the pneumonia cases. Now the floor is open for question, and I will start reading the first question in our chat. I think this question is for Dr. Bhaskar. How effective is the pleural tab in isolation the organism in necrotizing pneumonia?
Yeah. Let's see, the microbiological diagnosis is the mainstay in making a diagnosis of any infection. Especially, as I told, in lung pathology, especially pneumonias and all, it is very difficult to get a sample because we don't do lung biopsy, which is invasive and not possible. So wherever there is a possibility, we should take the sample and send it for appropriate tests. When there is a effusion, you can tap it. And now that we have interventional radiology or the ultrasound guided aspiration can be done. And that fluid, if you send, of course, we will be much better placed in treating the child pneumonia effectively. And in the fluid, you can do the biochemical tests. Not only that, the gram stain or the PCR can be done, and culture also can be done. And as I told, the blood culture yield in pneumonias is very less, maybe some 10 to 15%, or some studies 20%. But what they have found that the yield of culture from the yield of organism from the pleural fluid is much better than the blood culture. So having said that, in addition to the routine investigations, it is better if there is a fluid, we should send for microbiological examination in addition to other things I told. But culture is also equally important because the yield can be much better than the blood culture.
Another question to Dr. Vanitha is how the A line produced.
Yeah, A lines are reverberation artifacts of this. As I already said, they are artifacts. The pleura, you can't really see air. You can't see the lung image because air is not very friendly to ultrasound. So in the window where you shine the ultrasound beam, wherever there is air, because there is pleura interrupting it, there is to and fro reflection, and each reflection is equidistant to the distance of the probe and the pleura. So you will see parallel horizontal lines because of this, and it only means that there is air in your path of sonographic evaluation. So in the insonation part, if there is air and there is to and fro reverberation because of this, because air scatters the ultrasound beam, and this is captured again by the probe in equal distance, and this is why parallel A lines are formed. So how they are formed is like this, and what you interpret is aviation, presence of air.
Another question to Dr. Bhaskar. What are the indication for surgical resection of necrotizing pneumonia?
Pardon?
The indication for surgical resection.
In necrotizing.
Yes.
See, usually most of the necrotizing pneumonia, they recover well with the appropriate antibiotic for a longer duration. The need for surgical thing is very, very rare, except when it is gone into gangrenous thing, the lung, as I told, because as it is necrotizing pneumonia is a the vascular occlusion which occurs, thrombosis or whatever it is, that is responsible for that. And rarely they go into gangrene. And with the routine treatment, if it is not improving, that's the only indication for surgical resection. Otherwise, most of them, though it is called as complicated, though it is called as severe pneumonia, the morbidity is more, but most of them recover. And one good thing is that most of these cases occur in an immunocompetent child. And that is where the important lies, and most of them recover well.
Okay. Any question
In
from
fact,
the
it is said avoid any surgical intervention if you see necrotizing pneumonia because the complications are more. The bronchopulmonary fistula is a complication again, leading to secondary complications in pneumothorax and such. So try and avoid any surgical intervention if you're contemplating necrotizing pneumonia. And as doctor said, they respond well, although aggressive treatment is what.
I have, sir, can I ask one question? See, in the ultrasound, lung abscess and necrotic pneumonia, is it possible to differentiate? Because the one thing is lung abscess, the walls are thick, and necrotis the walls are thin. Any other differences that makes you think that this is abscess, this is necrotizing pneumonia?
Dr. Vanitha? I think she have a problem with the internet again.
Yes, sir. Yes.
Yeah. Any question from the audience?
Yeah, necrotizing pneumonia are.
Okay, Dr. Vanitha.
Am I audible?
Yes, yes, ma'am.
Am
Yes.
I audible? Yeah.
Yes.
So, and probably multiple cavitation, micro cavitation of necrotizing pneumonia coalesce together to form an abscess kind of picture also. So eventually lung abscess also, I think Dr. Bhaskar will be more authoritative to suggest this. There is not a suggestion of draining lung as in any abscess as an indicated intervention. As in distinguishing necrotizing pneumonia from lung abscess, one of the things would be checking on the around the abscess will be of normal architecture and normal non-pathologic, and probably release of necrotizing pneumonia will be have graded amount of loss of perfusion. That will be one of the distinguishing factor. So that may not be hard and fast rule, but as such, sound in the lung space would be good. Was that right? Was I lost?
Yeah, the sound is not clear.
Okay, basic thing, lung vascularity around the abscess probably will be good and retained. That will be one of the factors that you can assess.
Okay, any question?
If you have questions, you can email to us also. We'll be able to respond to your questions also.
Open the mic and you can ask your question.
Okay, thank you all for attending on a Sunday evening. And special thanks to Dr. Bhaskar, who chose Dr. Bhaskar for us, invitation. And it was a very useful presentation. And to summarize, Dr. Bhaskar, probably
You are not heard, madam.
I must thank Dr. Bhaskar. He responded to my request immediately, and I was very happy because, you know, pneumonias are his very infectious disease, especially pneumonias are his pet subject. And he's a sought after speaker for this topic. So thank you, Dr. Bhaskar.
Thank you, sir.
I think it came on time. Now it is the winter and we see so many cases of pneumonia. So I think this presentation came exactly on the right time.
Thank you, sir. Thank you.
Thank you, Dr. Bhaskar.
Thank you, sir. Thank you very much. Thank you all for that.
Thank you, Dr. Mohammed Salman. Thank you, Dr. Vanitha.
See you next year.
Yes, that's
this was a concluding presentation of the year. Thank you all for attending. Thank you. My apologies for poor audio in between. I was trying to tell a big thanks to all who attended, and special thanks to Dr. Ranjan and Dr. Bhaskar for accepting the invitation.
Very much.
And
Bhaskar
we will.
sir, good evening. Ranjan sir, good evening. Nice to
Good
listen to you.
evening, good evening, Jalil. I see that you are a regular attendee of this session.
Sir, this is very useful for a practicing pediatrician, those who are working in a ICU. So
yes,
excellent, sir.
Your thirst for knowledge has not diminished. I see.
Namaste, sir. Thank you, sir.
Thank you.
Thank you.
Bye, everybody.
Bye, everyone. Thank you.
Thank you, madam.
Catch you in the next.